Good day. My name is Dr. Jamie Ostroff, and I'm here with Dr. Smita Banerjee, both from Memorial Sloan Kettering Cancer Center in New York. And it is our pleasure to present our work looking at empathic communication as a solution for addressing the growing problem of lung cancer stigma. We have no financial disclosures, no financial relationships to disclose. So let's get to it. At a meeting like this, it is important to acknowledge that there is no question that the successes of tobacco control are heralded as a success in reducing morbidity and mortality associated with lung cancer and other tobacco-related diseases. However, there is increasing recognition of unintended consequences of our tobacco control efforts. And the unintended consequence that we speak of today is the unintended consequence of lung cancer stigma. So when we think about lung cancer stigma, we recognize its importance for several reasons. First off, is that lung cancer stigma is common. It's reported by as many as 95% of patients diagnosed with lung cancer describe experiencing lung stigma. Of particular concern is that nearly half of patients describe stigmatizing interactions with medical providers. Perceived stigma is associated with negative outcomes that are important. These include psychosocial outcomes, depression, anxiety, poor treatment adherence, delay in seeking treatment, misreporting of smoking status, underreporting of symptoms, and equally important, that lung cancer stigma, again defined as the experience and internalization of negative appraisal and devaluation of patients, is associated with poor healthcare delivery and other negative outcomes. In our presentation, we have focused on one particular avenue for reducing or mitigating lung cancer stigma, and that is the context of medical encounters with physician and other healthcare providers. We know that adherence to clinical practice guidelines for assessment of smoking history and cessation advice may trigger feelings of regret, guilt, and stigma. And our work is intended to bridge the importance of adherence to high quality tobacco assessment and treatment with the best practices of empathic physician-patient communication. A couple years ago, we conceived of a conceptual model of lung cancer stigma, and I show this to you here to illustrate that we're talking about, when we talk about lung cancer stigma, we're talking about an internalized feeling of stigma, several different moderators that influence variation and consequences. So this is a summary of what I've already described as really the way we begin to think about lung cancer stigma, and a recognition that one of the drivers of lung cancer stigma, and the one that we're going to be focusing our work on, has to do with the interactions, the social interactions with medical care providers. And lastly, what I want to describe is that we recognize that there are multiple ways to both prevent and mitigate lung cancer stigma. And this is a paper that Dr. Heyman led several years ago, published in JTO, where we highlighted multiple opportunities to address lung cancer stigma across the continuum. And we today are going to be focusing on this interpersonal, which we think is a highly constructive and promising approach towards hitting the target in preventing and mitigating lung cancer stigma. So for the remainder of our presentation, Dr. Banerjee is going to describe some of our pilot work as well as our future directions in using empathic communication to reduce lung cancer stigma in the context of medical care. Dr. Banerjee.
Thank you so much, Dr. Ostroff. We'll go to the next slide. So some of our previous work has really looked at this targeted intervention, which was delivered towards clinicians to reduce lung cancer stigma. And the intervention that we developed was called Empathic Communication Skills Training. I'll walk you through the development and testing of that. So we go to the next slide. The goal of some of our previous work was to develop and pilot test this empathic communication skills training to help oncology care providers better manage potentially stigmatizing interactions to reduce lung cancer stigma. We did this in 3 phases. The first phase was we had 12 lung cancer patient survivors from the Lung Cancer Alliance. Next slide. We did some qualitative interviews to really look at some clinical vignettes needed to develop trigger videos and other training materials. Then we had 30 oncology care providers. We worked with MSK Thoracic Disease Management Team and Pulmonary Service. These clinicians participated in a 2-hour empathic communication skills training. And then we did some data collection with both clinicians and patients. Next slide. We looked at patient-reported stigmatizing interactions. There were many that were reported by patients, but some of the key themes that came out were the repeated probes about smoking. They really increased this perception of stigma when things like you're constantly asked, did you smoke, by every medical provider that comes their way. And patients reported without providing a rationale for it, they feel that they are being stigmatized since they step into a hospital or a medical facility. The second stigmatizing experience described was presumptions about the patient, where even if the patient was a prior smoker, no longer a current smoker, the presumption was that they are continuing smoking at different times. There were patients also described blaming statements by different oncology providers who said things like, you wouldn't get lung cancer if you didn't smoke. What were you doing when you were smoking? What did you think will happen? So some of these statements also trigger feelings of stigma. And the last experience was disbelieving the patient, when the physician or the other clinicians would not believe that the patient has stopped smoking and hasn't touched a cigarette in 10-15 years. Going on to some recommended do's and don'ts from patient perspectives in terms of what can help deal with these kind of stigma. One, I'll talk about do's first and then I'll move to don'ts. Some of the things that were recommended by patients were clinicians should provide a rationale for asking smoking history. Why is it important to ask these questions repeatedly? Clinicians should undergo training on empathy and humanism. They also would like to hear from the clinician that lung cancer can come from a variety of causes, not just smoking. They wanted hope. They wanted clinician to have good bedside manners, sit with the patient, make eye contact, also offer resources and other supportive care services, as well as acknowledge that addiction is there and sometimes it might lead to difficulty in quitting. Some of the don'ts were, again, based on some of the stigmatizing experiences, were not ask about smoking behavior repeatedly, make prejudice statements or blaming statements, speak about the patient instead of to the patient, and so on. Moving on, based on all of this, we developed an empathic communication skills training module. It was a 2-hour training. We focused on a half-an-hour didactic, but the bulk of the training was spent doing role plays with trained actors, which we refer to as standardized patients. Moving on. So this was a blueprint for the training. We've published on the blueprint, and this is published in Translational Behavioral Medicine. Jim, you can go to the next slide. Responding empathically to patients, a communication skills training module to reduce lung cancer stigma. Next slide. What we found was, clinicians who participated in the training found it to be highly agreeable with them. So we had very high evaluations for all items of the training. Then we also focused on some patient-reported outcomes. And what we really saw was, overall, we did not see an improvement in the care outcome, the empathic outcome, and this was because of ceiling effects. Pre-training and post-training, we saw very high patient-reported outcomes, so there was not much room to move. Next slide. What we really found changes in was in the CAPS, the consumer assessment of healthcare providers and systems. We saw that clinicians who participated in training were able to explain more and had more information about the patient. We've published these results in CHEST, and you could look them up. Next slide, please. So the take-home message is that the clinicians who treat patients with lung cancer can play a really important role in reducing stigma. At this step, our next steps are to examine the effectiveness of a multi-site training that will be developed, that will be delivered virtually in community oncology settings, and look at both patient and provider outcomes. Thank you.